All right, so Dr. Becerra, we've talked a lot about the history and fundamentals of OCT. Let's explore image acquisition. Give me just the high-level overview of the basics of how image acquisition works with OCT.
Great. So in order for us to really capitalize on the method, you need to start with a quality image. The basic principle is that we must displace blood. Essentially, the near infrared does not travel well through blood. So you need a blood-free environment. In theory, how you achieve this can be anything that displaces blood, right? So in non-human subjects or in a non-heart situation, we explore in the past with a CO2, just to give an example. So if you displace blood with air, you're going to acquire quality OCT image. So there is nothing magic or magical on contrast, but because that's the media that we already have there, and because I always preach, like, when you do your OCT pullback, utilize this as one of your projections. You need to take that picture anyway, right? So I typically go one picture to wire and get the OCT inside. The actual pullback, I change my angle so I'm not adding dye, right? So that's what I do with 100% of dye.
So that's an interesting point that you bring up about contrast. A lot of the times when OCT is brought up, there are a lot of questions around contrast and will it increase my contrast usage? Tell me a little bit about your experience and then maybe some of the data that's out there with contrast in OCT.
Yeah, so I think the more you evolve on your OCT journey, you start realizing that it's actually an opportunity to save dye, but you need to change your workflow, right? So typically from any coronary that we consider intervention, typically we take more than one projection if you are doing angio-based only. This is not true with OCT, right? So with OCT, I only need one picture, one angle, and all the data that are going to start interacting there is within that pullback, right? So consider the nature of the method that is cross-section. I don't need different angles to characterize the lesion anymore. So I would, in a provocative way, challenge, like, if you want to save dye, is one more reason to do OCT instead of doing angio-based only. Recently, through the Light Lab initiative, we were able to quantify that there is no addition of contrast utilization when you do PCI guided by OCT. And in some cases, you really can save dye.
That's really interesting. How does the use of OCT impact X-ray exposure to the physician? Is there more or less?
It's the same mindset, right? I mean, because you don't need that many of projections anymore. You can actually save on radiation as well. So Megan, let me ask you this. You support many accounts out there. Where you see people struggling the most in terms of image acquisition?
So one of the most basic but overlooked pieces in the image acquisition portion that I see where people struggle is actually communication at the table, because it does take two people to work together in unison to acquire a good image. And so one of the things that I like to stress with people who are using the technology is knowing who's doing what at the table. It doesn't necessarily matter who does what, just knowing who the point person is for each task, who is injecting, who's triggering, are really, really important to making sure that we're getting a good image on the first try.
Yeah, so probably we could dive a little bit deeper on this topic and even simulate a little bit here. Why don't we do that? Because you're absolutely right. Like, even if I'm doing one of these actions, I'm verbalizing.
Yes.
So typically what I like to do is whatever position I'm on the table. Let's assume I'm on the first position. So I have the pedals, everything is in position to start the sequence. The first thing I verbalize is cine. Even if it's me stepping on the pedal. I say cine, so bring awareness of everybody. Then inject. I can be the one holding the manifold or someone else, but I verbalize this step. And then trigger, if you are doing manual trigger.
And what
right?
I really like about how you verbalize each step in that way is it does allow in an instance where, say you have a newer staff member or someone where we're not as confident in their ability to inject, you as the operator knowing what needs to be done, you can step in and be the injector. And by saying trigger, you're letting them know, hey, you just need to press this button when I say it. And so it does allow a little bit of pressure off of a newer or lesser experienced staff member. And it gives you more control as the operator to know, hey, no, I'm going to get a good injection this time.
Talking about trigger, what is your experience out there? Like, do people lean more on the auto trigger or manual trigger? How you go by that?
So it's an interesting topic, actually, and it's one that there's always a lot of conversation around. In my personal practice, I always like to encourage manual trigger because if someone can master the manual trigger, it's going to allow them to acquire images in maybe some anatomical situations that are a little bit trickier or we don't have as much flow as we would typically want. And typically I find that the image quality is better. And so my practice is to encourage people to let's really master manual trigger. If then you want to move to automatic and you feel comfortable with that, great, move to automatic. The software will pull back for you when it senses the right amount of blood clearance, but at least you have the skill set to do both. And when someone, in my experience, starts on automatic, it can actually be a little bit trickier to then try to learn the manual workflow.
That's right, and it's interesting for us to highlight that on Ultreon 2.0 you have the ability to also configure to user preference, even this aspect, right?
Yes.
Manual versus auto. And for new users, when we talk about manual and auto, what we're referring to is the trigger. The pullback is always automatic. Right, but the beginning or the start of the pullback can be triggered manually or automatically if the system senses that there is no blood around the catheter. And I agree with you. I think the more you do manual, I think you feel more in control. Mm-hmm. And there are situations, particularly on the pre-stenting, in which you might want to intentionally delay the trigger. And you can do so by setting your system to manual.
Talking about speed and trying to translate it into something practical, I know with the Ultreon 2.0 software, each physician can customize their own settings in their profile. And one of the options is pullback type, and it gives you the option of 75 millimeters or 54 millimeters. How does that translate to speed and where should a physician potentially look to be on that setting?
Tip number one, I strongly suggest that the default speed to be the 75 millimeters because it comes with the highest speed. We are talking about approximately 36 millimeters per second versus 20 millimeters per second on the shorter pullback. So think about what you gain selecting the longer pullback or the faster pullback. Obviously you gain longer scanner, so you don't need to be that precise positioning your lens, and we're gonna dissect this aspect when it comes to image acquisition. But again, even if you have a region of interest that is very short, by pulling back fast, at 36 millimeters per second, your odds to achieve good blood clearance increase. So I think this should be the default for virtually every pullback. What's the difference in terms of, that's another common question I'm sure you get, I get.
All the time.
That is about is there a difference in resolution, right, between the longer pullback versus the shorter pullback? And the answer is no. So when you look at the cross section, all the parameters that we discussed before, actual resolution, lateral resolution, are the same. The difference is that the space in between each individual cross section is different, right? So you have a more dense numbers of frames if you go with a shorter pullback, and specifically is 100 microns apart with a shorter pullback versus 200 microns apart with the longer pullback. It's very difficult for me to justify a clinical need to be 100 versus 200 microns, right? So I systematically select the fast pullback because often gives you better image quality. If you ask me, okay, so when do we use that short pullback? Probably the only situation that is if you are dealing with a bifurcation in which you want a 3D reconstruction of the stent. Because then by having a higher density frames, your 3D reconstruction turns out to be better.
That makes sense. So if I'm hearing you correctly, it sounds like with the 75 millimeter pullback, you're going to get more information in a shorter period of time, and your likelihood to get a better image is going to be higher because of that faster pullback.
I think that summarized well. It's all about image quality, and you will be in a stronger place by faster pullback as your default.
So talk to me about the different modalities that we can use to inject contrast, manifold versus a power injector.
Sure. I would suggest for the lab not to change their preference, right? So you can go either. So if you practice with manifold, probably the number one tip is also don't change your syringe. So stick with your small syringe, either 8 cc's or 10 cc's or even 12, but don't go beyond that. Mm-hmm. I see people make the mistakes, because it's an OCT, I need a big syringe. The problem with the big syringe is that it's very difficult for you to generate a good flow with your hands, and flow is the key aspect on displacing properly blood, right? So, and this is also not a motivation to keep the fast pullback, the long pullback, right? Because if you have a fast pullback, you don't have much time. If you have a small syringe, you don't have much time to pull back. So you need to keep the fast pullback as your standard setup. If you go with a power injector, remember, it's all about the flow. It's not about the total volume, right? So I would recommend for the left system, probably 4 cc's per second, the setup, and 3 cc's for the RCA. Then you do a simple math. Fast pullback takes 2 seconds. You add 1 second to give you some margin there. So if you have a flow rate of 4 times 3 seconds, 12 cc's for the left. If you have a flow rate of 3 seconds, 9 cc's for the right, which is probably just a little bit more than what you would have done for your common angiogram, but not by much.
Dr. Becerra, let's talk about guide selection. As we know, with any intervention, the guide is the foundation of the case. How does the role of the guide impact OCT and image acquisition?
Yeah, so again, I think it's important for you not to change your routine. However, to your point, yes, it is the foundation, and the better guide engagement you have, the less waste of dye, and the more effective is going to be your ability to clear blood through the vessel, right? So the number one aspect of good OCT pullback is proper guide engagement. So keep it safe. If you can even be selective in one vessel, if you don't have proximal osteal disease, be selective and concentrate all the dye on that vessel, right? The okay angiogram might not be okay OCT pullback, right? So when you see a lot of dye coming back into the sinus, that dye that is not helping you clear your vessel of interest, right? So guiding selection or good engagement is key, right? On the 4P that we preach for many years, the puff aspect, that's my variation of the 4P. I'm not looking at the OCT image. The puff is to look guiding engagement. And a common mistake is that, okay, I'm going to advance a little bit my OCT. Now my guide is moving away, and when it's time to inject, you're wasting dye into the sinus and not properly clearing your vessel.
So as far as we've selected our guide, we know we're going to do OCT. When you're looking at the initial angiogram and you know it's going to be an intervention that you want to image or maybe don't want to image, what do you look for in a lesion in terms of vessel preparation and things like that to make sure you get a good OCT image?
Very important as well. So if you are imaging pre, your catheter is 2.7 French, right? So translating this in a 3.0 vessel, probably 80% lesion, you start getting close to be occlusive. So it is important for you to decide right there how important is the distal part of the vessel, or not the distal part of distal to the lesion, your interest of imaging. I have some case of ISR in which I intentionally didn't want to pre-deal. Even if you're occlusive, you're going to get good image at the level of the lesion, right, but not past that level, right? Most of the situation, you want to pass that lesion in order to scan for quality landing zone. So the only thing that is required would be a gentle pre-dilatation, typically with a 2.0, maximum 2.5 balloon. So there is space essentially created so dye can go through the lesion and displace blood distal to it.
So in your practice, how often do you find that you're pre-dilating before you do an OCT?
Probably a third of the case.
Okay. You mentioned ostial left mange, and ostial lesions as a broad classification is something that I get a lot of questions about in the field. And sometimes that translates into, oh, well, the lesion's at the ostium of the LAD or the ostium of the circ, or it's ostial RCA. How does OCT play into those scenarios?
Yeah, so Ostial LAD, Ostial circ, I mean, these are excellent niche for OCT. You are proximal in the vessel. Your ability to clear blood there is excellent, so it's a perfect indication for OCT. Aorta ostium, meaning left main and RCA, the problem is that the flow in the ascending aorta is too much to be clear, right? So again, there is maneuvers that you can try with a guiding extension, but I don't recommend leaning on this technology for purpose of imaging Ostial RCA or Ostial left main.